This is a brief introduction to the Hesch approach to the pelvis, and this is the workbook, which exceeds 250 pages at present, and is titled Treating Sacroiliac Joint Dysfunction and Lumbopelvic Pathomechanics, integrating the sacroiliac, pelvis, lumbar spine, hips, and symphysis pubis. The sacroiliac joint has certainly been controversial ever since 1932, when Mixter and Barr discovered the intervertebral disc as a source of pain and sciatica. Prior to that, recognizing sacroiliac joint dysfunction was recognized in the medical community, and you can find articles in which they use plaster casts, and you can find reference to surgical fusion. Smith-Peterson developed a fusion approach, and then after Mixter and Barr discovered the disc, the enthusiasm for sacroiliac joint dysfunction, of course, decreased. In the osteopathic profession, of course, they recognize that as an approach that would respond to manual therapies, and their landmark article was in 1957 from Fred Mitchell Sr., and it was a definitive article on collecting all of the thought on the mechanics of that structure. When I graduated from physical therapy school in '81, I took a job with Richard Antigny, who has published extensively on the sacroiliac joint, and it took me a while to even understand his work. And then when I did that, I started to pose questions such as, if the suggestion that anterior ilium pattern is common, then could there be an opposite one? Could there be a posterior ilium? And of course, looking in the literature, of course, you do find that in fact is described. My introduction to the SI joint was sometime before that, when I was 17 and had a terrific motorcycle accident, and certainly caused tremendous damage. And part of that, certainly, if you can forgive the language, torqued my pelvis such that when I learned how to treat it, made a significant difference. What we know today, based on lots of research, is that there are only a few studies that show good inter-test reliability with palpation and with motion testing, of which there are different types. And right now, in 2015, we're seeing a significant upsurge, as we have over the past 5 years, in the medical community actually embracing the term sacroiliac joint dysfunction. Remarkably, over the last 5 years or so, more than 10, and I've heard that 14 is the latest number, equipment manufacturers have developed different hardware for fusing the sacroiliac joint. Some of the studies make claims that it's based on good clinical research, and you'll find terms like that in the marketing that are actually dubious. And you can follow a Facebook group and encounter a large number of people who have had an adverse response to that kind of intervention. Lots of controversy on the injection studies. Basically, it's wide open for new knowledge, especially in diagnosis and especially in treating. When I was digging deep into the SI joint, I trusted my hands. And if I felt that there was ligamentous tension that was unresolved, correlating with the client's presentation, then I started to ask what else might be going on. And in response to that, and the fact that I'm not a very good visualizer, it's difficult for me to visualize 3D anatomy, I started to look at one structure at a time. So I took a pelvis and disarticulated it. And this is the outline of the SI joint, and all this is, of course, the posterior ligamentous complex. So I took a hemipelvis and I looked at it, and I looked at every landmark that was available, and I looked at it in the frontal plane, the sagittal plane, and the transverse plane, and then I could put together what an ilium might do, what an ischium might do, and what a pube might do. Now, of course, yes, they are all fused, we all know that, but there is phenomenon that occurs in the pelvis that is encountered only in the lower pelvis, meaning that the axis of movement is so close to the actual SI joint that palpating the traditional landmarks, the ASIS, PSIS, fail to discern it. The literature advocates palpating the top, the crest of the pubic bone, and the tubercle here. And what I found very valuable was to palpate the middle of the joint and the lower part of the joint bilaterally, and to walk across, looking to see if there was a distinct step down that persisted. Went on to name the anterior iliac shelf, that little portion just above the ASIS that's fairly flat. Much better intertest reliability for palpating those landmarks than for palpating the elusive iliac crest. And then the other landmark from the back was the flat portion of the ilium, which I named the posterior iliac shelf. And then I started palpating the flat part of the ischium, the medial part of the ischium in relationship to midline, and of course palpating ligament tension as well. In encountering Carl Lewitt's work early in the early 80s, it really spoke to me how if one muscle is tight, it's going to test stronger, and it will be inhibitory of the antagonist. And so that stretching the tight muscle seems very reasonable in balancing function. And I immediately took that to the joint, and I thought, well, what if you have tightness in a joint in one direction? In the opposite direction, what happens? Does that correlate with muscle function? And we know that it does based on the type 1, 2, and 3 receptors that we interact with, particularly the type 3 receptors, and found that, yes, in fact, it does correlate. And so testing for tightness in joint, actually for blocked motion, is a very effective way of improving neuromusculoskeletal function and restoring motion. The other thing that I encountered was that in cases of treatable hypomobility or significantly restricted movement, found that in the opposite direction there can be a hypermobility. So both sides of the bell curve, hypermobility, hypomobility, when there's a shift towards one direction, let me say that they both shift in opposite directions, in which there's an increase in hypo in one direction. In the other one, there's a shift away, an increase in hypermobility. And gaining motion is much easier to achieve than constraining movement. And there seems to be a tremendous amount of focus in some specialty groups on diagnosing and treating sacroiliac hypermobility. And it is my experience that actually testing the opposite motion and finding a treatable restriction greatly facilitates correction of the hypermobility. Of course, there are exceptions to that. The actual movement in the SI joint is very, very small, although there is about 3 millimeters of medial bone deformation of the ilia per a very good study. It's very difficult to accept that asymmetry of the PSISs and ASISs, etc., actually represent a movement dysfunction inside the joint. That being said, these asymmetries that are treatable improve this system, this lumbar spine, this pelvis, this pubic joint, this hip joint. So a very important perspective happened. It was a gift, and at one of the early International World Congress on Low Back Pain and its relation to the pelvis. And I believe that these were in 1992 or in the 1995 conference, which were held in San Diego and La Jolla. And an orthopedist had utilized those so-called pain provocation tests, which we'll cover later on. He demonstrated with a fluoroscopy that they in fact did traverse through the joint. The big question is, do they only isolate the joint? What other pain-provoking structures might they influence? When I saw that fluoroscopy, it was like, well, it was like an arthroscopy, because you can't define the structures, you know. Even in the knee joint, it just doesn't quite look like the anatomical text with labels on it. They're only viewing a small image of it and so on and so forth. But what was very distinct was to observe compression and release, compression and release. And it was, of course, a very small amount, but you could see the joint space, and regardless of which test was being done, you could see that phenomenon occur. And what it changed my paradigm at that time, which was that we can isolate movement in the SI joint, we can find when it's lacking, and we can increase motion in the SI joint to be much more of, there can be external restrictors that may account for a loss of motion. There are external structures that may inhibit muscle function and increase motion, but most importantly, it's not that motion in the joint must be evaluated and treated, which is difficult, but more that movement should be able to occur through. So it's not in the joint that we're focusing, but it must occur through. That's a much more functional perspective. So these are sprinklings of an overall philosophy of treatment, and they will be repeated at times in the text and in the videos. I don't want to belabor it too much. There are some parts of the book that won't be covered in video, such as a disclaimer at the very beginning of the workbook, and several quotations which are very nice, and I especially like Gregory Grief's philosophy, but we're not going to cover those and waste time. So, given that I had two very severe injuries early in my life, and then a life-changing car wreck in 1994, I had to work in ways in which I could work with the client and minimize stress on my body. So I started using fulcrums. And the more I dug into the literature on properties of connective tissues and joints, etc., it really spoke to me that structures need a low load and a long duration in order to move. And so that's the viscoelastic creep model of mobilization. In my own experience with different practitioners using different techniques, including manipulation and many soft tissue techniques and exercise, left me wanting. And I started to ask, what do I need to do to my body, and what do I need to be a better clinician and help the clients that I work with? So again, I started using fulcrums that would induce a pure glide. And I started treating the person for 2 minutes for some of the named dysfunctions of the pelvis, and for some of them 5 minutes, and have discovered a pattern which is covered in the text, which is called posterior glide of the sacrum. And that pattern I utilize 15 minutes, but it's a one-time correction. So, in summary, this treatment approach is based on using a fulcrum when appropriate, using low load, long duration forces, evaluating it on a system basis, in other words, not just focusing on the SI joint or the ilium, rather looking at multiple proximal and distal structures. Actually, it's within a whole body paradigm. And then in digging into the muscle energy model and the osteopathic biomechanical principles, I came to question some of those and was a bit confused at times. For example, when they speak of in-flare and out-flares being rare, I found it so frequently after correcting an anterior ilium or a posterior ilium, and I thought it was just odd. But later on I came to realize they really were speaking more of medial and lateral movement based on the joint shape, which I choose to test in sideline. And I test it with passive motion, springing the anterior ilium and then the posterior ilium, testing it bilaterally. And it is rare. The pattern I found, which I have named type 1 in-flare, out-flare, because it's much more common, is much more of an anterior posterior migration with some medial migration. Went on to discover over a dozen movement patterns that are not described in the literature, and came to expand on some, such as anterior ilium being not just uniplanar or biplanar, but actually being triplane phenomenon, and negating several things that did not hold out to be true in the pelvis, and those are covered in detail later on. And then lastly, this work is predicated on a very strong patient education model, teaching them self-treatment for these patterns. And in doing so, found that some patterns go away with one treatment. And so some of these do not need to have repetitive treatment when treated within a whole system approach. Some do tend to recur. I certainly blame the vehicle. We're in Colorado in the United States of America, and our steering wheels are on the left side of the car. And I believe it has to do how we get in and out of the car, get in and out of seats, functioning in a right-handed world, because even left-handed people get this most common pattern that we'll be discussing later on. And in that most common pattern, a person can have up to 11 different permutations involving the hip, the pelvis, mobility through the sacrum, through the ilium, and through the pubic joint. And by treating all of those, then many of those will fall away. For those patterns that tend to recur, we do teach self-treatment. So this should serve as a basic introduction to our model of evaluation and treatment. And in summary, the contribution that I believe I made is a uniquely thorough palpatory assessment and integrating multiple landmarks and a systematic three-dimensional technique for identifying landmarks. And standing landmarks do not always correlate with what you see on the table, and we respect standing posture and gait, but understand also that when the person lays down, you're going to see a truer picture of what's driving the system. So much of our palpation is based on what we see with a person unweighted and prone and supine, more so than what we see in standing. And the technique of doing passive motion testing through the joint is very different from the gross movement tests. The gross movement test where you palpate bony landmarks and you have the person go through gross movement, and then stating that evaluates movement inside the SI is actually a false paradigm. And there's certainly a lot of research to validate that it is a false paradigm. So I tended not to trust those. I appreciate that sometimes symmetry is achievable and is beneficial, but we can have a symmetrical sacroiliac joint dysfunction, which the joint is blocked and there's no movement going through it, with a passive evaluative test, or that there is excessive movement in it, which are treatable. So symmetry does not necessarily define SIJD. And the technique of doing the spring test I started doing in 1981 when I read about the fact that the SI joint acts like a shock absorber. And to that I would add it also acts like a force transducer. And having tested the shocks on my vehicles, I started to test the joint the same way. So I would take up the slack in the structure, and then I would double that force. If it took 15 pounds to take up the slack, then I would impart another 15 to see if there was any additional movement. And just like the shock absorber, I wanted to appreciate the recoil. And a lot of manual therapy schools of thought teach to grade movement based on the forward thrust. And I must say, once you do the recoil, you'll never go back, because I find the forward thrust testing to be very difficult limited inter-test reliability, and the recoil testing is just much more informative, such as, for example, you might be able to take up the slack in someone, you might be able to induce a little bit of movement, but if it's hypomobile, it'll bounce back very quickly, firmly into your hand. If it's hypermobile, then there's going to be a slow recoil, and if it's a normative structure, if it's functioning normally, you will be able to take up the slack, induces a forward spring, and the recoil will tell you more about the integrity than does the forward test. It's something that with trying you can appreciate. And just want to make sure that I'm being fairly thorough. And I think that does serve for a general introduction. Thank you.